Hello, and welcome to this evening's RLI Power Hour webinar titled Pandemic Impact on the Workforce. My name is Dr. Jennifer Nathan, and I will be co-moderating this evening's session with Dr. Bob Pyatt as we are co-chairs for the ACR RLI Power Hour webinar series. Before we get started, there's just a few logistical items that we want to go through with you so that you know how to better participate in this evening's event. So when you join this evening, you join through the Zoom platform. At the very bottom of your Zoom window is the Zoom control panel, and you can see an image of it right here. There are two icons that we want to draw your attention to on the control panel. The first is the chat icon, which I'm circling here. The chat icon is what you'd use if you're having any sorts of technical issues. So you had a technical issue, click the chat icon, up comes the chat window, type in your concern, hit send, and then our support staff will be reaching out to you to help you resolve your technical concern. The second icon we want to draw your attention to is right here, the Q&A icon. The Q&A icon is what you would use if you want to ask questions of our faculty. So click on the Q&A icon, up comes the Q&A window, type your question, hit send, and we will then see it on our end. You're welcome to submit questions at any point during this webinar. However, they will only be collected and not addressed until we get to the dedicated Q&A session at the very end. One other item that we do want to let you know about is that this is a recorded webinar, and that also includes the Q&A session. So just something that we want to make you aware of. So I'm now going to turn things over to my co-moderator, Dr. Pyatt, to introduce this evening's faculty. Dr. Pyatt.
Thank you, Jen, and welcome everybody. We have quite awesome three faculty this evening for you guys. So here's some brief bios. So Sabiha Raoof, MD, FACR, is the Chief Medical Officer and Patient Safety Officer for Medicis Health Network in Queens, New York. She is also the chairperson of radiology for Jamaica and Flushing hospitals. She has helped transform her two radiology departments to provide high-quality, patient-centric care and achieve the designation of Diagnostic Imaging Centers of Excellence from the ACR. Being a breast cancer survivor herself, her passion is to promote person and family-centered care. Dr. Raoof has received several grants from Avon and Susan G. Komen for breast cancer education and outreach. She is the chair of the Quality Experience Committee at the ACR. She is also a member of the Clinical Decision Support Committee for the ACR. She is also one of two physician editors for Imaging 3.0 case studies for the ACR. Dr. Rove worked with CMS services on their Transforming Clinical Practices initiative, and she served as a national faculty leader for this project. Currently, she has been invited by CMS as a clinical champion for the Quality Payment Program, known as the QPP. Serving as a clinical champion provides an opportunity for Dr. Raoof to collaborate with CMS in a voluntary capacity, sharing her insights to the program and representing a community of her peers. This exciting partnership with CMS allows her to help communicate with the QPP, providing leading-edge perspective on the value of the program, identifying successes and challenges, and sharing valuable feedback. Eric Rubin, MD, FACR, is a diagnostic radiology, serving as the Associate Chair of Radiology for the Delaware County Memorial Hospital, and he is also the Medical Director of Computed Tomography for the Department of Radiology at Crozer Health, and he is a partner in Southeast Radiology Limited, a private practice radiology group that provides imaging services to Crozer Health. He received a Bachelor of Arts degree from the University of Pennsylvania and graduated from UMDNJ, which is the Robert Wood Johnson Medical School. He subsequently completed his diagnostic radiology residency at Thomas Jefferson University Hospital in Philadelphia and a fellowship in abdominal imaging at Beth Israel Deaconess Hospital in Boston. Dr. Rubin serves as chair of the ACR Human Resources Commission on the Board of Chancellors and is a member of the ACR Economics Commission. He is also the CPT advisor representing the American Rentgen Ray Society. Eric lives in Media, Pennsylvania, near Philadelphia, and with his wife, Amy, and three children, and their dog, Louie. Dana Smetherman, MD, MPH, MBA, FACR. Dr. Dana Smetherman is a diagnostic radiologist who specializes in breast imaging. She is the chair of the Department of Radiology and is an associate medical director for the medical specialties at the Oxford Medical Center in New Orleans. Dr. Smetherman is currently the Secretary Treasurer of the ACR, and she serves on the Board of Chancellors. She has also served as chair of the Breast Commission of the ACR. In addition to her roles with the ACR, Dr. Smetherman has served as president of the Radiological Society of Louisiana. She has also been an ACR counselor from Louisiana, a board member for the National Accrediting Program of Breast Centers, and also she has served as chair of the Technical Exhibits Committee of the RSNA. She's also been an advisor to the current procedural terminology panel of the AMA. And she is also chair of the Breast Economics Committee of the ACR and as a physician director on the board of directors for Ochsner Health. Dr. Dana Smetherman has given numerous presentations and has multiple publications in the areas of breast imaging and healthcare economics. It is quite a pleasure to have these three fantastic faculty here this evening. And we're going to start off with Dr. Dana Smetherman. Dana?
Well, thank you so much for having me. I'm going to share my screen just give me 1 minute. I need to get my slides in the presenter view, and let me just do this. Wait, why is it doing that? Almost there. Okay. So you should all be seeing my slides now, I hope. I'm going to talk to everybody tonight about really that first wave of COVID and what early trends we might have seen at that time that predicted what, and I don't think this is overstating it, the seismic shifts that we are seeing now in our workforce. So that first wave, or the alpha wave, as we think of that through the lens of our radiology workforce, I want us to think about, well, what was our focus? What were we thinking about at the time? What else should we maybe have been thinking about? And also what underlying trends were perhaps accelerated by COVID and could have predicted the labor shortages that we're seeing today. Now, if you look at this graph at the bottom, these are the actual numbers of the COVID waves at the facility where I work, Ochsner Medical Center in New Orleans. And as you can see, we were really pretty badly hit in that first wave back 2 years ago now in March of 2020. We had Mardi Gras, which was a super spreader event. And we saw our cases. We saw our first case about March 12th. And by the end of March, we had 900 inpatients in our hospital system. So like Dr. Rove in New York City and other colleagues in places like Seattle, we really were at the forefront of this. And as we were, all of us going through this together, what I was thinking about, I bet what all of you were thinking about were things like, how do we get enough PPE? How do we distance people in the reading rooms? In our facility, we actually went to platoon scheduling because we're a training program. We might have 4, 5, 6 people in one reading room. That was not going to work. We wanted to make sure we had enough PPE for our colleagues who were actually working on the COVID wards. Like many of the rest of you, we did 3D printing of face shields. We actually made our own masks, Ochsner branded masks. There were breweries in New Orleans that switched over to make hand sanitizer. We were also focused on getting our COVID testing processes filled up, drive-through testing, all different kinds of things. And then on the radiologist side, we were quickly trying to figure out how we could put in place things like remote workstations. So, as I think about it, I think what we were all really thinking about at the time was safety, the safety of our employees. And then if we look, kind of what else were we thinking about? Well, I think we were really all concerned about our employees. Immediately, many of them had to have their children come home and do remote school. They were having to feel like they were teaching their children, figuring out childcare at Ochsner, where I work. We actually stood up free childcare, partnering with a bunch of schools in the area for all of our employees to try to help them so they could continue to work. The ACR put its Being Well Together wellness program together. And you also see at the bottom right of this slide what we did at Ochsner, trying to basically make sure that our employees were paying attention to their wellness. So again, I think at that time, we were worried about the wellness of our employees. And then another thing that we were all really, I think, focused on was, what were our volumes going to look like? The graph that you see in the bottom in the middle was our actual volumes at Ochsner. The one that looks pretty flat and grows across the top is 2019, but the one that takes that precipitous dip in March is what happened in 2020. And like all of you, we saw this abrupt drop in our volumes. We were thinking about things like the V-shaped recovery versus the U-shaped recovery. Were we going to have to see a salary decrease? Were we going to have to furlough our employees or our fellow radiologists? At the time, I was the chair of the Breast Commission, and we made the unprecedented move of recommending that we pause screening to do things like conserve PPE, make sure that we were keeping our patients and our staff safe. And actually, although there was a lot of support, we did get some negative comments, particularly from technologists who were worried about their jobs. So I think we were really worried back then about jobs and financial security. But as I kind of now with 2 years perspective, think about, well, what maybe should we have been picking up on at that time that we didn't realize because we were so focused on these immediate needs? Well, one of the things I think we all know now is that while we were worried about the safety of our employees, they were also extremely worried about their safety, to the point that some of them, said, this is not what I signed up for. All of us, I think, have seen these statistics. 20% of healthcare workers have quit their jobs because of the pandemic. Many have left the industry altogether. And if we look back at what an underlying trend, so the graph on the right-hand side, which is from the Bureau of Labor Statistics, actually shows the U.S. labor force participation rate. And what we notice is, though it does drop precipitously at 2020, it was already trending down. So the workforce, at least the labor force participation, was already shrinking. And it seems like COVID just accelerated that. So, that was one, I think, underlying trend that we're seeing now. A second thing that we probably should have been thinking about was, as our employees thought about their wellness, they weren't just thinking about their wellness at work. They were reevaluating their whole lives in a very holistic fashion. Those two-income families, now one of them had to stay home and take care of their children. They kind of looked around and said, maybe we could live a simpler life. Maybe we don't both have to work. The rest of our lives are working very nicely. Childcare is much easier. Maybe we could forego that, trip to Disneyland or buying a new car. So, I think not just the Great Resignation, but the Great Rethink is what was going on. And also, it didn't really start with the pandemic. I also think another thing about remote work that we've all seen is that people found that they've been losing autonomy, particularly healthcare workers and physicians, and being able to work remotely, they found that they liked it. They were able to regain some of that autonomy. Some of my colleagues talk about, maybe I want to go flip that load of laundry while I'm reading studies. I can do that and I'm still very productive. So I think people had a chance to regain some of that in their lives. At the bottom part was a projection of what the North American teleradiology market would look like. And this was put together before the pandemic. My guess would be that if we actually updated it, it would be more dramatic now. So what's another thing we should have been thinking about? Well, as I said on my kind of like, what were we thinking about? I think we were concerned about financial security, our own financial security, the financial security of our colleagues and other healthcare workers. But the interesting and I think unexpected thing was, as you see that stock market graph on the right-hand side of the slide, yes, there was a precipitous drop, but it wasn't sustained. It actually recovered and went even higher, which gave many people the opportunity to retire, perhaps a little earlier than they were planning. So financial security did not turn out to be in the long term as much of a concern as we thought it was going to be. In the face of that, at the same time, however, our imaging volumes, as we all know, went right back up pretty quickly. And now all of a sudden we have fewer people in the labor force. And we have as much volume, if not more, than what we had before. Basically, the situation in which we find ourselves today. Finally, just kind of to take one last minute to talk not only about the physicians, but what was kind of going on in the nursing and tech labor market. So if you look on the left-hand side of that slide, those two graphs are about radiologic technologists. So even back in 2019, the unemployment rate for radiologic technologists was actually hovering around 1.5 or 2%. So that's already telling us there was a labor shortage, and it was an aging workforce. The average age of employed radiologic technologists in 2019 was actually 42.9 years. And then on the nursing side, I think everyone in the country who's got access to a newspaper or a television is quite well aware of the nursing shortage. This is a headline from a New Orleans newspaper. For some Louisiana nurses, COVID was the last straw. And if we look finally at that graphic that's on the right-hand side of the slide, they were predicting a shortage of 1 million nurses by 2022, and it was the aging population and people going out of the nursing field. But what was interesting to me about that is that is data from 2017. So these things were already underlying our healthcare workforce even back in 2017. And I'm sure that if we looked at updated data, it would be much more dramatic than that. So I am going to pause there, just kind of my reflections on what we were thinking about, but what we probably should also have been thinking about during that first wave. So let me stop my screen sharing if I can get to that. Okay.
Well, thank you, Dr. Smetherman, for that great overview of the early stages of the pandemic. Just a few questions that I thought of that I wanted to ask you and our other faculty members. If you could go back in a time machine to the beginning of the pandemic back in March of 2020, what would you have done differently?
Well, one thing that I would have done differently, one of our partner technology schools decided not to enroll a class in 2020. And I would have said, please don't do that. I probably would have gone to high schools and said, hi, who would like to go to nursing school? Perhaps our health system can find some scholarships for you, because those people would be available now. So I definitely think that when in some areas, at least in my facility, when people kind of shrank the workforce artificially, that was clearly not the right thing to do. I think we should have kept our foot to the pedal. So that would certainly be one thing for me. I'd certainly also, at that time, there was a lot of concern about AI replacing radiologists. I would have told young people looking at radiology, don't be concerned about that. You're going to have plenty of job security.
Perfect, thank you. Any comments from Dr. Rubin or Dr. Raoof? If you could do anything differently in the beginning, what would you have done?
Not so much what I would have done differently. And again, my experience with this COVID pandemic was a little different from my radiology colleagues, because I was dealing with not just radiology, but 90% of my time went on managing the clinical issues throughout the health system. So I do wish that, and I'm sure you had the same issue in the changing recommendations from CDC was driving us crazy during those early days. I would go out there and tell my employees they don't need to mask. 2 days later, you are masking. So they really, that trust was gone. They really thought that I was doing that because we didn't want to use up the PPE. And that was creating an issue. I think those changing recommendations was really something that was very challenging to deal with during those early days.
There are two interesting things, and I'll mention one of the things I'll be talking about when I speak a little bit later is the fact that my institution, as well as I'm sure many others, dismissed some of their staff on the basis of their unvaccinated status. And I think that having done so may have been short-sighted. Obviously, it was considered to be the right decision at the time, but I think we were essentially giving away staff that we probably needed or would be needing down the line. And I think that also an earlier leveraging of a more broad approach to teleradiology and telework would probably be helpful in bolstering any levels of stress that we felt with respect to covering shifts.
Perfect. Another question is, you talked about physician wellness and how that was an issue during the pandemic. What if each of you learned from the pandemic on what we could do to improve physician wellness and keep our numbers, the workforce, at a stable level?
I think we all have to make this a tremendous priority. I feel like almost the whole healthcare profession has PTSD. So I think we have to do every single thing that we can think of. Right now, I feel like our physician colleagues and our employees are like gold. So we are doing things like we're doing ergonomic assessments this year on every single area in our department, just because we want to make sure, that our employees are in good shape physically, that we're not putting them in awkward positions. So I don't know if there's too much that you can do on the wellness front. I do think allowing people to have more flexible work schedules, which is a desire. I think you have to, again, acknowledge that and try to find a way to do it, because I think people are just crying out to try to find balance between their work and their life and to deal with all the stress.
I agree with you, Dana. So even before COVID, because we have a large ambulatory network and we could not find enough ambulatory physicians, we had to start right there, like really creating flexible schedules. You want to work 12-hour shifts, fine. You want to work 3 days a week, you want to work 4 days a week. So we were trying to create that flexibility, but for our employee wellness, not just for radiologists or physicians, only for our employee wellness, we really realized very early on during the pandemic that our employees were not only physically exhausted, they were emotionally exhausted. And lucky for us, our behavioral health team really put in a program together very quickly, where they were sending out teams to the floors to talk to physicians, residents, doctors, nurses, whoever, ancillary staff, to make sure that they have emotional support. And we had a big collaboration through Greater New York Hospital Association, where they helped us create recharge rooms in our hospitals, where we provide massage therapy, we provide some art therapy. They have a time they can go and sit and talk to somebody from our behavioral health team. And I think we really need to start thinking about the emotional wellness of our teams going forward.
So I'll mention two quick things. The first is that, at least within my group, my view and the view of our leadership is that as a small private practice group, a feeling of family is very, very important. One of the things that we were doing before the pandemic is we were intermittently scheduling after work activities for our group to meet up, so that we were doing things out of a work environment. We spend more time with our work colleagues than we spend with our own families, and not having that connection can make it very, very difficult to work as a cohesive team, and therefore diminish the stress level of that cohesive team. And the other thing that I would say is that to me, the major issue that can cause burnout is a feeling of a loss of control. And if there's one thing that people can have felt in the last 2 years, it's a complete and utter loss of control. If you start to feel that loss of control in your work environment, it's going to have a significant impact on your wellness, in my opinion.
Yeah, just real quick, last question. Based on your experience throughout the pandemic, was there any specific type of work schedule that you found to be successful amongst your staff?
So, we have, it's been interesting. One of the things that we've done recently, we had alternate scheduling, at least with our radiologists, for our emergency radiology group. And we, like 7 on, 7 off, or 7 on, 14 off schedules. And in order to try to increase our subspecialty bench strength, we have actually recruited for, and then had some people in our group decide that they wanted to adopt that schedule. So, and again, we're just trying, I've had, 3 years ago, I had 4 people who were part-time. Now I have 15 in my department. So again, and it's hard to run a schedule with that amount of flexibility. But I think if you don't give people that, the job market is so wide open, they'll find someone else who will. So.
Exactly. So in my department previously, maybe I would have 1 per diem or 2 per diems to help out on the weekends. Now I will take whatever you give me because I need to cover the volume in the department. I think we have become way more flexible than we would have thought a year ago we would be.
I agree with that. I think that a feeling of flexibility or a work environment that is flexible for radiologists is something that is extraordinarily important to those candidates that we talk to. And I think it's a nationwide phenomenon that is just growing and growing.
Well, thank you to all of you for your comments. I'm now going to turn things over to Dr. Rove.
Can you see my slides?
Yes.
Okay, great. So again, thank you very much for giving me this opportunity to present today. As was mentioned earlier, I am the Chief Medical Officer and Chair of Radiology for Medicis Health Network in Queens, New York. So I would like to give you a little bit of an introduction to my health system. Medicis Health Network is a safety net system. We have 2 hospitals. Jamaica Hospital is a very, very busy level 1 trauma center. In fact, we are the busiest trauma center in New York City. And our Flushing Hospital is a smaller community hospital where we see more a geriatric patient population. We cater to a lot of nursing home patients. We also have a nursing home associated to our Jamaica campus and have a large network of ambulatory sites throughout Queens. So those of you who are not familiar with Queens, Queens is the most diverse county in the United States. Our patient populations speak 135 languages. Our own staff speaks about 60 of those languages. We are very sensitive to who we recruit into our teams. We want our teams to be reflective of the patient populations that we serve. We also have jumped both feet into a value-based model. We take 100% risk for 173,000 capitated lives. And I'll talk a little bit more about that because it was relevant to us during COVID. Very busy ERs, we see 165,000 ER visits a year. We do serve a very diverse patient population, but 60% of our patients are on Medicaid, 20% are on Medicare. We do see about 5% uninsured patients as well. For our radiology practice, we are a hospital-based group. We have 20 radiologists that cover both the hospitals. We perform about 220,000 exams a year. And both of our departments are diagnostic imaging centers of excellence. We are very, very focused on providing patient-centric care in our 2 departments. Just a little bit perspective from the epicenter of the epicenter for COVID-19. Dana did cover the first wave, but my perspective was a little different from my CMO role. So like all of you, we saw our first patient on March 3rd of 2020, but in the next week or 2, the numbers really started escalating at a very rapid rate throughout the hospitals in New York. And we basically, all we were seeing those days was COVID patients. We also have a very robust emergency management system, and we have a lot of ambulances attached to our own system. And it was very unfortunate during those first early days to see how many people were pronounced dead in their homes due for other non-COVID illnesses because they were so reluctant to come to the hospitals. What was also difficult during those days was the disease was new. Nobody knew what to look for. The presentations kept changing, the treatments kept changing, recommendations kept changing. So it was quite challenging for all of us to deal with it. And especially in Queens, where our patient populations have significant social determinants of health, they have significant burden of chronic diseases, very, very prone to getting sick. And at some point, we would have the entire families admitted to the hospitals because we have multi-generational families living in very small dwellings. So it was impossible for them to isolate if one member of the family got sick. And this all caused not only physical exhaustion, as we said, but also emotional exhaustion for our teams. The number of deaths that we saw during that first wave was really emotionally draining for all of us. At our busiest day, we had 550 patients in our 2 hospitals, and 150 of those patients were on ventilators. All our ambulatory physicians were pulled for ambulatory sites to cover inpatient unit in the hospitals. All the employees were pulled in to help out inpatient services. So that first wave was really quite significant for us to deal with. So as we came into the summer of 2020, COVID numbers had gone down, but people were very reluctant still to come back to the hospital. So our ER numbers were down. Our ambulatory sites were not seeing as many patients. Our radiology numbers were also significantly down because people still were not, even though we had resumed elective procedures, people were still reluctant to come back for their routine mammograms or for their elective procedures. But by early 2021, the number of patients that we saw, there was a significant increase in patient volume, not COVID, non-COVID patients. Our critical care units were over capacity. We had 50 to 60 critical care patients in our hospitals, non-COVID patients. A lot of patients had postponed their care. Our trauma numbers skyrocketed. We had 3 times increase in gun violence in our trauma program. Our stroke numbers increased. And because of all that, the volume that we were seeing in radiology was significant. As I said, we had the return of elective procedures and other procedures, but then the pre-testing before those procedures was creating another headache for us because the test supplies were not there. We also had some lessons learned from the first wave that we wanted to prepare for the second wave. We had to pull nurses that were normally not in critical care units or physicians that were not managing critical patients like we did. And we had an opportunity during that time to retrain those nurses. With Greater New York Hospital Association, we had created an educational program to put our non-critical care physicians through a teaching program to show them how to handle critical care patients. Because of the large number of patients we had on ventilators, we had oxygen supply issues during that first wave, which we had to resolve before the second wave. Not all the patients had monitoring systems, and with patients being in isolation, we had the need to create monitoring systems in all of the patient rooms. And again, as I said, the staff wellness programs, which really picked up very early on, thanks to our behavioral health department, continued to be provided during that period as well. I do want to talk a little bit about our vaccination program because you all probably realized how reluctant our minority populations were to get the vaccines. So what happened, we had decided that we are not only going to provide the vaccination program to our own employees, we were going to expand it into the community. Most of our employees are from the community, so we expanded after we finished with our employees, we expanded to other families of our employees. Because of our VBP model, we do have patient navigators who are from the community, who are bilingual, who help our patients navigate their healthcare. We used those navigators who had already built trust with our patients and this community to be educators for the vaccination program. So by the end of all that, we were very proud to provide 55,000 vaccinations in our two hospitals for our community. So by August of 2021, we started seeing the Delta variant and an increase in the number of COVID patients that we were seeing in our 2 hospitals. That wave for us in New York lasted from like the first week of August into the middle of October. That was also the period that we were preparing for the booster doses for our employees and for the community that we had already vaccinated. Things were different with the Delta variant. We saw that patients who were vaccinated, the severity of disease was not as much as those for unvaccinated. And during the first wave, what had happened is that all the New York hospitals were really inundated. So when we had full capacity in the 2 hospitals, we really had nowhere else to send patients because every single hospital in New York was facing the same overcrowding issues. So my CEO and I, one day we reached out to Albany Medical Center, which is 150 miles away. At that time, upstate New York really was not seeing any surge of COVID patients. And within 10 minutes of calling them, they had an agreement with us. And we transferred about more than 100 patients to Albany Medical Center. The critical ones were airlifted. The not so critical patients went by ambulances. And that really, really helped us because those patients really would not have had any place to go in the New York area. But by the time we had the Delta wave, almost all hospitals in New York and around the country were now dealing with COVID. So all we had was our 2 hospitals to do the load balancing internally. But with Delta variant, by that time, we also had better treatment options. We were not using as many ventilators. We were first going to non-invasive ventilation, far less deaths than the previous wave. Testing supplies were way better and the PPE issues were resolved by then. Our governor here had mandated us by the summer of 2020 to have a 90-day supply of PPE in stock. And we had really done well with that. And we had really 120-day supply, which we still do for PPE. In radiology, as I said, by early 2021 and through now, basically the number of cases that we are doing in every area, especially CTs and MRIs, has gone significantly higher. What has also happened during this time, like all of you just mentioned earlier, is the staff shortages. I have ads out there. It's been a year and a half, not finding any radiologists. I have radiologists who had been with me for over 20 years now rethinking what their priorities in life are. I do not want to have long commutes, so some of them wanted to be closer to home and took up jobs closer to home. Some of them came back and said, we are happy to work with you, but we need remote options only. We are not going to be coming in. Some of them want to work 4 days only. So things that I previously would have been very reluctant to provide, I now have no choice but to deal with all those flexibilities and provide the flexibilities because I need the staff from wherever I can. Similarly, for technologists, very, very difficult to find technologists. Here in New York, being amongst all the larger academic centers all around us, we also have the issue where they get better salaries, better benefits in these other larger, bigger systems, which we as Safety Net Hospital cannot provide them, which is another big struggle for me. We are a very busy trauma center, so our night coverage was provided by a teleradiology company. In the middle of 2021, we received notice that they're going to be pulling out their services because they cannot find radiologists to cover all the hospitals that they were previously covering. So very quickly, we had to scramble looking at companies. Most of the teleradiology companies do not want to work for New York hospitals because of our malpractice issues. We were lucky to find a company that was willing to work with us and very quickly having to do with their contracting and getting them credentialed so that we can have them in place when the previous company pulled out. Again, radiologists, technologists, everybody now wants more remote options, more flexible schedules. But this is not just in radiology. I'm seeing the same issues throughout my health system. Most of the ancillary services, especially the services that can be non-clinical services that can provide do work from home now just want to work exclusively from home. A lot of our IT people want to work from home. Our ambulatory physicians, our hospitalists, everybody wants flexible schedules. Nursing, respiratory technologists, lab technologists having similar staffing issues everywhere. We now have partnered with a lot of nursing schools to have those nursing students come through, hoping that they will stay with us. But again, being a safety net hospital, we have those challenges where we really cannot match up with what these staff members are getting in other hospitals, the benefits that they are getting, the higher salaries that they are getting, which is a big challenge for us. During the first wave, because not everybody in the United States was seeing the COVID surge, we had a significant number of volunteers come from all over the country. But by the time we had the Delta variant come, we had COVID all around the country, so we really didn't see any volunteers coming to New York from any place. We also, as Eric said, we also had to deal with the vaccination mandate for the healthcare workers around the same time. Here in New York, by September 27, we had to have all our healthcare workers vaccinated. They did make it easy because they did not make, they had very specific indications for health related issues, which made it a little bit easier for us. So we had two buckets. We had the employees who had the health exemptions, and we had the bucket where employees wanted religious exemptions. So for the ones who had health related exemptions, it was easy. It was our physician who looked at all of them and granted it based on the validity of those exemptions requested. For the religious exemptions, what we did is we created a committee, a very diverse committee of members from all different areas of the hospital, different backgrounds, different ethnicities, different religions, and that committee really looked at all the religious exemptions, and at the end we really did not give any religious exemptions. We did lose some employees, but a very, very small amount of employees. So at the end of the day, we really were not, we did not have to lose a lot of employees because of the vaccination mandate. I do want to talk a little bit about value-based payments, since I said that our system has really 50% of our business is in value-based payment models. And we realized during COVID that that was something that really helped us through this pandemic. Many of the larger systems who are more for fee for service did see a lot of loss of revenue. We still had a steady stream of revenue come in because of our value-based payments. It really helped us through the pandemic period. But it also helped us with our patients. As I said, we do have a very large navigator program and care transition teams who normally take care of our patients, help them navigate their healthcare systems, look at their needs because of their social determinants of health and all the other needs that they have, just not physical needs. We had that support team reaching out to our patients during the pandemic, making sure that they're being taken care of, identifying who those high-risk patients are and providing support for these patients. So I think our lesson learned from the from the pandemic is that we really need to focus more on our value-based payment models, expand those models, try to see how we can provide more services on our own campuses so that we don't have leakage from our network for that book of business. So the key points for me was really now we really need to be more creative on how we allow work-life balance for our staff. As I said, we're going to be focusing more on our VBP arrangements because that really helped us through this pandemic. We as a safety net system had been for all these years talking about social determinants of health, how we need to really be thinking about making healthcare more equitable to everyone. And we are very happy to see now everybody focusing on the social determinants of, be it CMS, be it our own state health departments, but everybody is now focusing on that. And we really are trying to move the needle on that within our system and working with our health departments and working with CMS to see how we can make healthcare more equitable in this country. My questions for the audience, which I think we'll discuss later, but that's the end of my discussion.
Sabiha, thank you. That was really superb, taking us through the pandemic from that initial phase now to the Delta variant, beautifully presented with so many issues and challenges, especially ones that are very unique to your situation there in New York. I'd like to reconvene Dr. Rubin and Dr. Smetherman to see if they would like to make any comments on the second part of our presentation this evening. Any further observations or comments? Dana, Eric, please.
Sure. I think one thing as I was listening to Sabiha talk, I was remembering how the Delta wave was the one that was called the pandemic of the unvaccinated. And I found that the stresses on the workforce were a little different. In the first wave, I think people were like, they rose to the occasion and there was a great sense of purpose. And, in this one, I found there was a lot more conflict. There was a sense of just exhaustion, that they were having conflict with patients that wanted ivermectin. There were unhappy people. There were people denying that they had COVID. I can't have had COVID. And so it was this kind of a different twist, I guess, of the psychological stress. But again, I think had just that, again, we saw more people leaving the workforce because, they were like, well, I was okay when I was like the firefighter, running into the burning building and I was going to save people. But now I feel like it's just, I'm getting emotionally and verbally abused. So as I was listening to Sabiha talk, I just really remembered that part of it, which you kind of forget after all these waves, right?
I agree with you, Dana. So during the first wave, people had that adrenaline surge. Everybody wanted to be out there helping our patients because patients really couldn't do much to do. They got sick. It was nothing that they did wrong. In the second wave, I heard it multiple times as I was going through the hospital, like, it's not fair. They have the option of getting vaccinated. Why are they not getting vaccinated? Why do I have to risk my life and my family? It was a very different mindset by then.
Thank you for those comments, Eric.
It's interesting reflecting on what Sabiha is saying when you talk about New York City and the stresses that were put upon New York City during that second wave, that Delta wave, are quite interesting because in my suburban community, we didn't have that crush specifically from patients. And I'll talk a little bit about what really became our stressors, more so than patients, were stressors on the health system itself, that became an issue as it just became more and more difficult to continue to move forward. And I think I'll leave it at that for now.
Thank you, Eric. We'll just do one more question here for the panel and then we'll transition to Eric. There's so many aspects of this that we could talk about. Another one I was thinking about was the relationship between the radiologists and the technologists and the staff and the DI management team, how that evolved from the very beginning to later phases. Any of you wish to comment on that?
Yeah, I will. So, I have a very cohesive group, and we have our retention rate in our system is very high. So many of us, I've been here for 25 years. My CEO has been here 45 years. My CFO has been for 53 years. And that if all of our clinical leadership, if you look, and most of my radiologists have been with me for 20 years. It's only in the recent few years that some of them are now at retirement age, and now I have to start looking at the younger faculty joining us. But over these years, like even if there was times when, say, one radiologist had young kids and had some needs, if there was some resentment voiced, I didn't see that happening now. I see people being more willing to help out colleagues now. So, oh, my kid is sick, everybody else is fine, you stay home, you read from home, we will take care of that. I see that more collegiality happening more now. Similarly, for our techs during the pandemic, when CT and MRI were not busy and diagnostic was getting overwhelmed with the number of portables that we were doing throughout the hospital, our CT techs and our MRI techs were going out on the floors, helping them move the portable units, help them move the patients. So I think it was that sense of team. I feel that more now than ever before.
Thank you, Sabiha.
Yeah, I would say one thing that I think, and I really appreciate having webinars like this one. I think one thing that's been kind of a challenge for us anyway, as we think about the physicians, and I'm over some other departments in addition to radiology, is I think that it's taken people a little while to realize that these labor shortages, whether it's techs or nurses, are not unique to our health system. They're not unique to our region. They're national and even potentially international. And I think a lot of the physicians have been so focused on just, taking care of patients, working as a team, getting through this pandemic. And I agree with you, there is a lot of esprit de corps. But I think I've had to remind lots of different people. I find that, we have 100 hospital beds that are closed because we don't have nurses to staff them, that we are not offering near as many extended hours, starting last summer in our outpatient imaging centers because we don't have the technologists, and, we're going to prioritize putting the technologists in the hospitals where we need them. So to me, I think that's been sort of a tension and a reminder that I've had to impress on a lot of people, and just sort of an education gap. And so actually I was really delighted to see the RLI kind of taking on this topic so that, people can really come to realize that we're all in this together. We're all facing exactly the same challenges. So.
Great comments. Thank you, Dana. Okay, Eric, did you have any comments, or would you just like to, we'll roll into your Omicron phase?
Yeah, I'll give my slides in a minute, but the one thing I do want to say is what's most interesting to me is that what we all have to realize is radiology and radiologist work is a little different, despite the challenges and stressors that we all face. The one thing we all have to recognize, and I think is under-recognized, is that our technologists in particular were the patient-facing component of our field. And I have to say, I don't think that we give enough recognition to how important and how important their work was and is throughout this entire pandemic, especially early, because if you think about it, they're the ones that were right up there in patient faces and at the most risk, and are at the most risk. So I really think that that's something that we as the House of Radiology really need to recognize and reflect upon as we go through all of this and go forward. Bob, do you want me to just go right into my slides here?
Yeah, that's a great comment too. Yes, if you don't mind, we'll go into Omicron and the phase 3, and then after that we will get to our lessons learned. I'd like to thank Dana and Sabiha for comments there.
So I'm going to take a little bit of a different approach to this. My talks are, as often as they can, a little more, and I like to be a little more informal. And you can see my title here, and I think this is, it's a little bit tongue-in-cheek, but what I want us all to recognize is that what a lot of what's going on is us trying to figure out, again, how we can regain some control over what we do on a daily basis as radiologists and within the field of radiology. The one thing I would add to my bio that I don't know if it was mentioned is that I'm also currently serving as the president of the Pennsylvania Radiological Society. So a little bit about me. I'm a general diagnostic radiologist in private practice for the last 18 years in a group in suburban Philadelphia in Delaware County. For those of you that watch Mayor of Easttown, it's based upon Delaware County, Pennsylvania. We have about 20 to 25 radiologists, and I live in the local area. I live in Media, Pennsylvania with my wife, my 3 dogs, and our quarantine puppy. And this last line is going to be something I'll talk about in my last slide, is that my family opened, my wife and I and our children opened a local small business in October 2021. And I'll expand upon the why we did that in a little bit and why it connects to all of this. My goal here, though, is just as much as I'd like to tell you about my experience during the COVID pandemic, I really want to impress upon you and really ask that you also tell me and tell us what how you experienced it, because I think we all really need to learn from each other rather than simply having you attend here and listen to us talk. A little bit about the first wave of the pandemic, March to June of 2020. My experience, and again, these are all my personal experiences and reflections upon what happened in a bit of an informal way, is that it felt as if it were a very chaotic and fluid situation. There really was no ability to plan anything more than a couple days or a week in advance. During that period of time, you really felt as if you had a complete and utter loss of control over what was about to come or what was occurring. And I have this line in here about decreased stress. And one thing that I think about is how little image reading interpretation I did during that period of time. And that part of my life was from the standpoint of reading large numbers of imaging studies really fell off the map as our volumes just cratered. My group really had to come to grips with figuring out, we already had a teleradiology solution that we'd implemented a few years before for call in an effort to improve our work-life balance. We were thinking about work-life balance before the pandemic, and we really were trying to figure out how best to leverage that technology and capability. How many people did we need to maintain in-house? Did we need to ensure that we were showing ourselves not running away from the hospital during the pandemic, but running towards the hospital and caring for the patients and being involved in the healthcare system? Or did we keep people at home, try to keep them safe so that, and away from what people were perceiving as a situation where they could contract COVID and become very ill? And then from a group perspective, did that mean we would have worker shortages because people were sick during that period of time? And it was very difficult to figure out that balance. As Dana mentioned, and I think all of you can agree, our mammography volume was intentionally cut down to almost nothing for several months. There was a significant difference. And again, as I said before, the patient-facing radiologist versus, or patient-facing radiology professional versus the non-patient-facing radiology professional. So our IR radiologists really were deep and very deep into the throes of what was going on with COVID, whereas I, as a diagnostic radiologist, to some extent was somewhat separated from that. There is a little bit of sense of guilt on my part for that too, because you really, to some extent, it was very difficult to truly comprehend what it felt like to really be in the trenches at that time as a radiologist. Our hospital beds were filled with COVID patients, and our outpatient imaging referrals just plummeted. But again, as I mentioned before, I'd really like to know, is this similar to your experience? Are we completely different out here in suburban Philadelphia than what you experienced, or is it very similar to what you saw? And then we moved on to the Omicron variant. And whereas the first wave, we really saw an impact on how our group functioned. The second wave, or the Omicron wave, really affected our hospital system. We had significant destabilization within our hospital system, either maintaining staff with staff quitting, or as I mentioned, we had staff who were dismissed because they couldn't, or because they weren't vaccinated. And we also had more staff that were sick, that were contracting COVID and therefore were kept out of the workplace. And there were times where we had to significantly contract our ability to provide outpatient imaging services, especially MRI, because we didn't have enough technologists and we couldn't hire staff. And all of these things really led to rapidly increasing labor costs. And my hospital system is owned by a private equity firm. And it had a very striking impact on them. I think they panicked when they realized that they had no control over this component of their business. And when their goal is not only to provide healthcare, but also to provide returns for their investors, it creates a bit of a complex interplay, especially when they couldn't control the labor costs. We also had a significant bottleneck within our emergency department. Because we didn't have enough staff, we had to close beds. Because we had to close beds, we had more patients who had to be housed in the emergency department. And therefore we saw a bottleneck. And there was a point in time when all of the hospitals in my community, inside and outside of my health system, were on a divert status. And it was very, very difficult to figure out where to take patients. And because we didn't have enough staff, one of our 4 hospitals was closed. Now, as far as the impact on the radiologists, we had an unexpected change in radiologist availability. It was very, very difficult to hire for the needs that we had. We did have progressively increasing volumes, especially in the evenings, especially coming out of our emergency departments, whereas in the first wave, it seemed like none of the COVID patients were being imaged. In this Omicron wave, it seemed as if we were imaging, and I'm sure it wasn't true, we were imaging everybody. And everybody, for some reason, was getting a CT angiogram of the chest and an abdomen and pelvis when they were coming through our emergency department. We also saw a bounce back in our mammography volumes, but I think we also saw a shift in our screenings, such that we had a significant lull in our mammography screening volumes between March and June of 2021. And again, I'd really like to hear your experience and whether or not this matches up to what you saw. If you have anything to add, it would be great to hear from all of you. So what's next as we moved out of this Omicron variant and into the whatever the next phase is? I think we're moving in a somewhat confusing direction. So my hospital system was put up for sale. It made the national news. They had ballooning labor costs. A letter of intent has been issued for another health system to buy our health system. And at the same time, another one of our hospitals, it's been announced, will be closing. Now, what's interesting about that is, although we're seeing some churn within our workforce and it's difficult to hire, this contraction of the number of hospitals that we have is going to decrease the number of emergency department imaging studies that we do. So inadvertently, we might actually be seeing an unintended balancing of our workforce within our group relative to what we have in our hospital. We actually may end up in a pretty good situation because of it. And then there's this issue of teleradiology. It seems as if many trainees and radiologists are seeking teleradiology opportunities. What that does is it puts us in a situation whereas in the Philadelphia area, many people tend to come here because they have roots here or they have family here. So the salaries can be variable across the country, and the rates of the salaries may not be as high in my area as they are in other areas. However, when you have radiologists seeking teleradiology opportunities, what you're essentially doing now is you're competing against the entire country with people who now don't have to put roots down in a specific area. They can live wherever they want and seek those teleradiology opportunities. And therefore, what that does to our workforce and how our workforce evolves because of it is going to be quite interesting, in my opinion. We also moved from a place where we had teleradiology companies as the providers of these teleradiology services to groups that now have large components of teleradiology within their group. One of the things I'd like to ask all of you is what your thoughts are on teleradiology, because one of the things that we've been asking in the Human Resources Commission is, what is teleradiology now? What has it become, and why is it preferred by so many? And if you have different opinions or other opinions on this, I'd really like to hear what you have to say. As far as beyond the office, this is where COVID had a very interesting impact on my life in general, in that even though the COVID pandemic has been horrendous on many fronts, what it has done is it's really given time to consider opportunities. What things have my family not done in their lives that we could do now? It makes you really think about whether or not you haven't taken the chances that you could take when you had the time to take them. So in February of 2021, my wife and I had a convergence of ideas about a concept that I had been thinking about that would be a great business in my hometown. And due to circumstances that simply aligned, we were able to and decided to take that plunge and opened our own business. And I think the important thing about this is it makes you realize that radiology or our work and how radiologists work in our profession, we're very much moving from a place where we lived to work to a place where we work to live. And I think we all should recognize that we need to take those opportunities when we have them. And we can have a work-life balance, and do things that are really important to us and possibly very important for our communities because of the positions that we're in and the opportunities that are provided to us. The last thing I'd say is, what does a return to normal look like? Because we are eventually going to have to, and we already are to some extent, living with COVID. It's not going away. So how are we going to return to some semblance of a new normal? And again, my last question for you is, what did you do during this pandemic? What did you add to your lives and change in your lives that you felt was a change for the better? Thanks.
Well, thank you, Dr. Rubin. One question I did have for our other faculty is, how did the Omicron wave differ for your hospital systems versus the others?
It was very different. So the Omicron was more challenging because we were losing staff. One person in the department would get sick and the next day we would have 3 or 4 more. So the Omicron wave was more about staffing, losing staff than actual patients coming into the hospital. That's what at least we had in New York.
I will say that it seemed to be to a far greater extent an outpatient event. In Louisiana, I just saw a statistic that 450,000 people had Omicron. We only have about 4.5 million people in the state. So that means about 10% of people had Omicron, and it was stunning. Everybody had it. My husband had it. There was every family, it seemed like, and just like Sabiha said, our workforce, I think we had 4 radiologists out at one time with it, which I don't think we've ever had 4 people sick out at the same time. So So I do think that it was very interesting. But the other thing that was really interesting about it, and I guess, we're all remembering our biostatistics, is it came on so fast. Like we were talking about it at Thanksgiving, and then within days, it was like popcorn. I mean, it was amazing. So, so it was very different. Unfortunately, we did see a lot of people who were vaccinated, fully vaccinated and boosted, who had it. But yeah, to me, I think it was just the sheer volume of cases.
Thank you for your comments. Let's go ahead and move on to the lessons learned. Let me pull that one up. Okay, can you see my screen?
Yes.
Okay, Dr. Pyatt, I'll turn this over to you with this segment.
Dr. Nathan, do you want me to just go through these, or are we waiting for Dr. Pyatt?
Let's just go ahead and get started with your slide, and we'll just go through the faculty with their lessons learned.
Sure, no problems. So I jotted down these two notes as I was thinking about my slides, as I was creating my slides, that I don't think that COVID necessarily has changed the radiology that we practice, despite the fact that we put in our reports when we see it that this looks like COVID. So the clinical implications of what we see and the education that we have behind us that help us read on a daily basis really hasn't changed, but the way that we practice radiology very much has been impacted by COVID. And I think that we also have to recognize that on a micro level, our radiology practices have been affected, but our health systems have really been impacted by this. And there's a very deep connection between how our practice of radiology is changing because of the way that these health systems are changing.
Dana, do you want to summarize yours?
Sure. Did we have the?
Excuse me, Dr. Raoof.
Yes, I think so. Yeah.
Sorry, I had to unmute myself. So yeah, as I said, I think we are really focusing now on how to provide those flexibilities that our staff is looking for their work-life balance, not just in radiology, in every area, in every department. We have to be thinking about that. And as I said, what we realized as a health system, small health system amidst much larger systems all around us, we realized that for our survival, those VBP arrangements are really the way for us to go. And we have been really focusing on how to expand that book of business, because not only did it give us a steady stream of income during the pandemic, it also gave us the setup that we have with our navigators and the care transitions teams to really care for our patients. Even when they were not in the hospital, they were still at home, but we still had connections through our navigators and care transitions team. As I said, social determinants of health, something that we've been doing for years, but now the focus is on. So I have spent the last 6 months really putting my teams together, collecting data, seeing how we can now really see trends of where our patients are, how easy it is to drop. I'm sure in your systems you see providers struggling with dropping Z codes. We are trying to work with the IT team to see how we can drop those Z codes. We know that CMS down the road is now going to be having hospital health equity scores, which will be really based on collecting this data. So we're really focusing on these issues and trying to see what we need to do to make our VBP arrangements much stronger, because that was really helped us survive through this pandemic as a small safety net hospital system.
Thank you. Dana?
So my sort of lessons learned is that I should have been probably paying attention to underlying trends that were going to be markedly accelerated by COVID, and that probably could have predicted the labor shortage we're seeing today. I do think that remote work is here to stay. it is now feasible and it is good enough. It's, it's almost like everybody used to have fancy Sony TVs and now the Samsungs and the Vizios are good enough, right? Workers desire not only flexibility, but I think Eric was kind of hitting on this too. Like, people want autonomy. They want control of their lives back. And I think we ignore that at our peril. I also think that people really are assessing how their work and their family and the rest of their lives all fit together. It has not become easier. The childcare issues were just unbelievably challenging for families during this time. So, I think we got to find a way to make all the aspects of our lives work. Someone actually told me recently, if you didn't basically reevaluate your whole life as a result of COVID, there's probably something wrong with you. So, and then also, I think we all maybe knew in the back of our minds that there were nursing and technologist shortages, but boy, are they just a feature of what all of us for every day now. And to Eric's point again about really the unsustainability of just this tremendous escalation through the roof, unaffordability of the premium labor costs that we are all facing right now. So those were my lessons learned.
Relative to Eric's question, his challenge question about teleradiology and all that, I have heard from recruiting firms that there's a 60% decline in candidates wanting to find an on-site job. 60% decline. Candidates call a recruiter and I don't want an on-site job. I want a teleradiology job. I also saw that match day was real good this year for radiology, and we have a lot of medical students interested in radiology. That's a good thing. And maybe there are a lot of them are thinking teleradiology. I don't know. But just trying to think what other factors there are going on here to help us fully understand the question that Eric has posed there. Are there any other aspects to this that we haven't thought of? We've mentioned a lot of different things, the flexibility of it and so forth.
Yeah, I recently was interviewing somebody who was literally finishing his fellowship, and he opted for a teleradio. And I was asking him, do you so early on in your career want to be like sitting at home reading, not having any interactions with anybody in the hospital? But that's what he wanted. He just didn't want a on-site job. And what Eric was asking about, I don't think, Eric, it has become a choice anymore. It was, for me especially, it has become like a need because I cannot find on-site radiologists. I have a busy trauma center to run. I have a busy stroke center to run. I need to provide coverage. In the past, I would never have allowed final reads from a teleradiology company because I wanted to have control over the quality of the. Now, that's all they will do. They will only do final reads for you. And I had no choice. I had to give in.
I think actually, Bob, your point about what has happened in the match day is absolutely, and the whole residency interview process is absolutely fascinating, because this is the class that entered their clinical rotations in the summer of 2020. And while I am absolutely delighted that there were 0 unfilled residency spots, and I think that the future is very bright for radiology, I do have to wonder what that is telling us about what those students experienced and how they want their careers to be. So
part of it too is you wonder, I know that there are some studies that have shown the young people don't want to do a lot of procedures, and which an on-site person would have to do, whereas teleradiology, you don't have to do procedures. And I just wonder if a little bit of this whole interest in telerad is that they don't have to be at the hospital getting interrupted to do barium enemas and shoulder joint injections, and they just would like to, be at home and so forth. But Eric, I hope we're helping you with more insight into that issue that you're asking.
Yeah, thank you. And Bob, I think that's an important point, is the issue of procedures is very, very concerning to me. As HR Commission Chair, one of the things I have been repeatedly mentioning is this concept of the gap. And we are going to have, if we are going to by necessity, expand our teleradiology workforce, and therefore really look carefully at how many people we truly need sitting in a hospital at any one time, we are going to find ourselves, if we don't plan for this now and figure out how we're going to fill those gaps with people who have the competence and confidence to perform those necessary procedures that whether we like it or not are going to have to be performed by radiology, we're going to have a lot of trouble. And there's a recent study out that I think came out within the last couple of days that I saw, that many of these procedures are now, whereas many of these procedures that were handed down to radiology over time because the clinical services didn't want to perform them, I think we're starting to see a swing back where those procedures are now being recaptured outside of the radiology sphere, and they are being performed by the clinical services, and they're being performed by non-physician radiology providers.
One
Yeah,
of the-
I'm seeing that a little in my local health system, actually. But do you want to say something, Jen?
Oh, yeah, we do have a question from one of our participants. They're asking, are you having to overpay for teleradiology in the way that hospitals are having to overpay for traveling nurses?
I can say yes, but nowhere near on the same scale. So it's definitely all I think the telerads companies are increasing. We don't have a large reliance on teleradiology outside of our own people that work remotely in our health system. But yes, they're all raising their prices, but it's not on the scale of nurses that make $10,000 a week now for a travel nurse. So that's my experience anyway.
Yes, absolutely. So for what I was paying for teleradiology, and I was doing preliminary reads at that time, but even so much more now, but not in any way on the scale that our travel nurses are getting paid.
Yeah, and what I'm more concerned about is, rather than price, is that I am concerned that because so many groups are going to need teleradiology services beyond what they're able to provide internally, these groups are going to become saturated. And I don't necessarily know that it's going to raise the price as much as it's just going to jump to the next step where they're not available to even provide the services. So then who's going to provide the services when we can't, and the teleradiology companies can't?
Erica, because I just did this in the last couple of months, it was a struggle. It was a struggle to find a company because they absolutely are saturated. They are saying that they cannot take anybody anymore, clients anymore. So I think this company was giving up a client and was able to accommodate us. Otherwise, I had nobody.
Yeah, it's interesting in our health system. And again, we don't have a big reliance on them, but we have some new administrators and they're like, oh, we need to go back and renegotiate these contracts. And I'm kind of biting my nails a little bit because, to your point, like, what if they're like, nope, thank you. We're too busy. Goodbye. So, because although it's a small amount, where we need them, we need them.
I actually had so when the last company told me they are pulling out, I found a company, and the day they were supposed to start, and luckily I have wanted them to start way ahead of when the other company was pulling in. Last day they called me, we got acquired by a bigger venture capitalist, so goodbye, we are not doing it. So I had to then start from scratch to find another company.
Well, we're just a little over, and we do want to be respectful of everyone's time. Any last minute comments before I turn things over to Dr. Pyatt?
Quick question for the faculty. Did you find any value to the ACR or the RSNA during the COVID pandemic? And if so, in what way?
I actually found a tremendous amount of value to the ACR and all of our professional societies. I thought they did a great job of immediately jumping in and filling the gaps on resident education. I also thought it was tremendously helpful. The guidelines that many of them put out, so that we could all be in it together, because those were difficult conversations to say you're going to stop providing a service for a period of time. So I personally was very appreciative of our specialty societies.
Yes, I also felt the guidelines were very, very helpful. Really didn't have time at that time to look at stuff. It was easy to go to ACR and get the guidelines for radiology. And I think also the couple of webinars that were done early on in the COVID pandemic by ACR and by the Radiology Leadership Institute were both very helpful to see how other people are handling those challenges and what we can learn from each other.
Yeah, I have to agree. I think that our ability as an organization, the ACR's ability to leverage pre-existing technology expertise to get information out there as quickly as possible and as broadly as possible, both in writing and video and webinar format, was very, very important, and couldn't have been done by any other way.
Yeah, I remember the attendance for one of those webinars was almost 1,000 people, which was huge. I think it was a record all time. But anyhow, I think in light of time, I'd like to thank all of our faculty. Eric, Dana, Sabiha, thank you so much for all of the information and comments and information tonight for everybody. Thank you. We'd like to say to the audience, please share your feedback with us. We will be sending you through email a webinar survey, post-webinar survey, and a recording of tonight's program will be available next week, and you're welcome to share that with members of your practice or department. The next Power Hour topic will be on population health management on Wednesday, May 18th from 7 to 8 p.m. And you can register for this as well as other upcoming RLI Power Hour webinars at acr.org/Power Hour. Again, thank you to Drs. Rubin, Smetherman, and Raoof for tonight's fabulous program. Good night, everyone.
Thank you and good night.
Good night. Thank you.
Thank you.